The topic which we would be trying to cover today. Have you heard about it? Enhanced recovery after surgery. Does anyone has got any concept about it? Azhar, would you like to say something?
Well, Assalamu alaikum, sir. Bismillahirrahmanirrahim. It's the word is expressing. It's quite clear that it's basically the manuals. It's basically the what we say that we can where we when do the manuals that from after the surgery patients incur recovery should be enhanced.
Other word for
Basically,
this protocol is fast track surgery. Okay. Like
okay.
in some places you will find the same word for this is fast track surgery. Okay. So enhanced recovery after surgery, like they want to reduce the hospital stay because hospital stay will cost more for the hospitals. A hospital stay will predispose the patients for undue infections. Okay. And also the turnover of the patient. Okay. So this is the basic concept. Now there are certain things which they have to do, and it's a multidisciplinary team strategy in which they try to use the way from surgical side, from anesthesia side, from logistic side, so that whatever you are trying to do, you do it in a fast track. So that's the name, enhanced recovery after surgery. Okay. So like you want to have minimum time of the patient in the hospital and quick recovery. Okay. Because what are the certain factors in what complications can occur if the patient has more stay in the hospital? Yes, Azhar.
Sorry, I didn't get it. Please come again.
I'm saying that first of all, one thing will be the hospital expenditure. Okay. But if you just think that what will be the problems if the patient has to stay in the hospital for a prolonged time?
Sir, definitely, it is definitely the burden, cost burden first. Second, the hospital acquired infection and workload, greater workload to the hospital staff.
Okay. Because one of the dynamic of this hospital this protocol is to ambulate the patient early. Okay. So now if you think about, if you ambulate the patient early, what will be the advantages will you get?
There will be less chances of complication, including DVT.
Like DVT embolism, if you ambulate the patient early, then less chances of ileus, post-operative nausea, vomiting. Okay. And
Yes, sir.
you are trying to minimize the infection as well. Okay. So actually this just a second, whose mobile, someone is receiving some call, I think. Okay. So we will just have a look on this. I will just share the screen. Just give me a second, please. So they started this protocol with colorectal surgeries and some orthopedic surgeries like joint replacement. And now they are in recent past, they are trying to use this in almost every surgery. Okay. So the basic concept, can you hear me? Can all of you hear me?
Yes.
Okay. So among the if we just try to figure out the factors among the anesthesia side, what do you think, what things you can do which will enhance the recovery and avoid post-operative complications?
Oral hydration.
Okay. What else?
Early mobilization, prevention of infection.
No, please try to be very specific. I'm asking, what are the anesthetic factors which you can do to reduce the post-operative stay and for this thing? One thing you
Regional
said.
lock.
The choice of anesthesia,
Definitely,
analgesia,
we will go for the
PUNV.
local anesthesia, sir.
Okay, just a second. First thing will be choice of anesthesia. Okay, so you will be using multimodal analgesia, and you will be using anesthetic medications which has less metabolism and less delayed respiratory depression or nausea, vomiting, things like that. Okay, so if you just try to be one by one, what are the factors for post-operative nausea, vomiting? Just try to quickly revise. One of who will tell? Azhar?
Opioid.
So it's
Opioids.
a
Okay.
middle ear surgery.
No.
Opioids, definitely.
No,
Sorry.
anesthetic factors.
Acha, use of inhalational agents and dexmedetomidine probably causes increased chances of PUNV.
No. Dexmedetomidine.
No, sir, not dexmedetomidine. I'm forgetting the name. Sorry.
Nitrous oxide is one of them. Volatile anesthetic is one of them. Neostigmine is one of them. Opioids is one of them. Okay, all of the opioids. What else?
Electrolyte imbalance.
Okay, fluid and electrolyte imbalance. This is on your side. What else? Use of regional anesthesia versus general anesthesia.
Hypovolemia.
Yes, fluid and electrolyte imbalance.
So yes, etomidate not PUNV.
Atomidate. Okay.
Sir, etomidate, sir.
Atomidate.
Actually,
Atomidate.
I forget the name. I mistakenly I said dexmedetomidine. It's
No.
basically etomidate.
Okay. So now if you just chalk out what are the surgical factors? So surgical factors are the middle ear surgery, any abdominal surgery, laparoscopic surgery. Okay. There will be more chances of post-operative nausea.
Orchidopexy.
Orchidopexy, like vagal, where this this vagus nerve is wandering here and there. The surgery is related to vagus nerve. They are posing at more risk. Okay, and what are the patient factors?
Increased IOP or ICP.
No, it's not the risk factor for PUNV. It is it is a sign of raised IOP. Raised ICP. We are talking something else. Okay. So what are the patient factors? Female gender.
Smoker, female.
No, non-smoker.
Yes,
Non-smoker.
smoking. I mean, heading is smoking, whether smoker or not.
No. The non-smoker has more risk. Okay.
Yes, sir. Yes, sir. I'm saying the heading, the smoking, whether it's present or it depends.
Okay. What else?
Peritonitis. Sir, peritoneal infections.
Peritoneal. We are talking about patient factor, Dr. Humera.
Sir, female gender, pregnant patient,
Yes.
or previous history of PUNV.
Very good. CRF. Okay.
CRF.
Okay. So these peritonitis is something else, Dr. Humera. Peritonitis will be causing acute abdomen, and that will be everything which is related to Aspiration because of gastroparesis is something else. We are talking specifically about post-operative nausea vomiting. Okay. So this is one of the component of the ERAS. We are not studying in detail. I'm just trying to tell you that what are the factors. So what else we can do? This is like we have to use the medication which has less PONV. Okay. Then what are the medications or what are the things which will delay the recovery? Like what will be the anesthetic factors?
Endotracheal tube retention.
Okay. Endotracheal tube.
Prolonged. Sir, if it is kept in for
No,
long
Dr.
time.
Humera. Dr. Humera, please think before telling, because I'm expecting a better answer from you. Endotracheal tube itself is not a cause of delayed recovery. It is to maintain the airway. Okay. It itself is not a cause for delayed, like it is not a contraindication for ERAS protocol. We have to use the medications, try to be focused on the medication. What medication would you be using? Propofol, less metabolism. Okay. Dexmedetomidine, less metabolism. As a whole, general anesthesia versus regional anesthesia. But among the regional anesthesia, what about spinal? Is it good or bad? Yes. Well, Dr. Humera,
It is
where
good.
are you?
Yes, sir, spinal is long acting, but mostly the patient recovers in a day.
Okay, if academically we don't have that medication with us, but if you are giving spinal, what is the medication of choice for?
Bupivacaine,
No,
Prilocaine.
no. Azhar, what is the medication which you should be using in if you are giving spinal for day surgery or ERAS?
2,3 chlorprocaine, sir. Short acting.
2,3 chlorprocaine. Okay. And what about bupivacaine versus ropivacaine? Because usually we are using this, none other is available frequently. So is it advantageous to use ropivacaine versus bupivacaine? It is better to use ropivacaine, okay, because ropivacaine has less motor blockade, so it will it is better to use. Okay.
And sir, less cardiotoxic also.
Cardiac toxicity is not related to recovery. Okay, that is correct. That is correct. Actually, ropivacaine and bupivacaine are both same. Okay, ropivacaine will have cardiac toxicity as higher dose. So you have more margin, more toxic level are required to have the cardiac toxicity as compared to bupivacaine. Okay. So what else? Another thing will be stress response. So how can you blunt the stress response of the surgery? These are the headings actually, which we have to just cover. The stress response, how can we achieve the blunting of stress response?
Carbohydrate meal.
Okay. What else?
Anxiolytics.
Okay, anxiolytics. What anxiolytic would you like to give?
Sir,
Okay. You can use bromazepam. You
Yes,
can
sir.
use benzodiazepine. Okay, among them, benzodiazepine usually, if you are giving immediate preoperative period, you can give midazolam because it will not have much hangover. Okay, and night before surgery, you can give bromazepam or alprazolam or lorazepam. Okay, so this is one of them. What else? Use of multimodal analgesia. Okay, use of multimodal analgesia. This will have a good effect on stress response. Okay, and this concept of carbohydrate meal is actually, what is the concept behind it? What are the hormones which are released in response to stress? Okay, there is a complex metabolic, hormonal, hematological, and immunological response. It is not only the anxiety, it is a metabolic response as well. Okay, that's why how, if you want to reduce the stress response, you have to use the preemptive analgesia. Okay, so preemptive analgesia is by the use of which medications we use for preemptive analgesia? Anyone, please?
Sir, gabapentins?
Gabapentin. Okay, what is the mechanism of action of gabapentin or pregabalin?
Sir, calcium channel blocker?
What group it is? It is basically anti-epileptic. Okay,
Anti-epileptics, yes.
and what is the main problem you can have practically when you are using gabapentin? Excessive sedation. Okay.
Sir, there is a role of carbohydrates. I think it reduces post-op nausea and vomiting. It has more role in that rather than decreasing the stress response.
Okay, just keep this point in your mind. We will just discuss. I think you are right correctly, but actually it is related to the release of stress hormones and insulin.
Yes, it reduces the insulin resistance, hunger, fatigue, post-op nausea and vomiting. That's
Yes,
what I
so
know.
that is the effect. It is also like, it is part of, you can say that it is part of stress response. Okay, so gabapentin, when you are using gabapentin, one problem associated with is increase sedation. And what are the advantage? It has opioid sparing effect. Okay, what else you use in preemptive analgesia? What is the concept of what is preemptive analgesia? What
So
is preemptive?
analgesia is given before the incision.
Before the incision, before the actual trauma. Okay, so it will modify the inflammatory release of inflammatory mediators. So not only
Yes, sir.
you are using other medications which you are using is NSAID. Other medication which you are using is paracetamol. So it is better to give paracetamol as part of preemptive analgesia. Okay.
What about epidural?
Epidural, yes. Epidural is also it can be used. Epidural is overall. I like specifically preemptive, and actually we can use different things in different scenario. Like for example, if you have a patient with fracture and you want to reduce the stress response, you can place epidural preoperatively to reduce the pain. Okay, so whole of the cycle will be, but usually nobody is doing it. Am I right? But actually, this is part of actually ERAS. The concept of ERAS is to reduce the morbidity or mortality, reduce the hospital stay, reduce the chances of complications. So stress response is one of the major factor which is it is causing a release of inflammatory mediators. It is causing hypercoagulable state. It is increasing the chances of DVT and embolism. So you are breaking that cycle. Okay. That's what they have written here. The sympathetic nervous system is stimulated by these factors in. And here is the role of what we were discussing. Just give me a second, please. Actually, my laptop battery was dying. Okay. So everything is clear up till now?
सर स्ट्रेस रिस्पॉन्स को ब्लंट सर स्ट्रेस रिस्पॉन्स को ब्लंट करना होता है ई-रेस लेस
Yes, we
मॉर्टेलिटी
whenever
के लिए या ई-रेस का प्रोटोकॉल है कि ई-रेस का एक बेनिफिट है स्ट्रेस रिस्पॉन्स
Vajia, sorry to interrupt you. Actually, some of the participants here are international, so please try to communicate in English. Okay. I understand your question. You are asking that whether this ERAS protocol is to blunt the stress response, but that's what you are saying.
Yes, sir. I'm asking this.
Yes, actually, enhanced recovery ERAS protocol is a multi-dimensional thing. Okay, we will just try to have a look on the surgical techniques as well, which is we will just come to that point shortly. Okay, it is not only to blunt the stress response. It
It is
has a
part
number
of
of
therapy.
I'm sorry.
Sir, basically it is the component of ERAS enhanced recovery protocol that blunting the response of surgery. It has many other.
It is. It. You see,
It
this
has
is
other it has other components also. It has preoperative elements. It has intraoperative elements. It has post-op elements. So decreasing the stress response is one component of enhanced recovery.
One of them.
Yes.
One of them. Okay.
There are many other things.
And they are actually these are correlated. Okay. When you are doing one thing, you are achieving a number of goals. Okay. Okay, Vajia.
Yes, sir. Okay, thank you.
Okay, so these are the hormones. Like this is the question which comes in the MCQ, that what is the hormone which is not increased in stress? So what is that hormone?
Insulin.
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 Insulin. Okay. Growth hormone is increased. ADH is increased. All other hormones are increased actually. Okay. And that is one of the reason of development of diabetes in patients having chronic stress or stressful lifestyle. Okay, so it is one of them. Okay, and actually not only the levels, it is the response, as Usman was mentioning, that there is insulin resistance. Okay, so this is the summary which we were discussing. ACTH, cortisol, growth hormone, insulin growth factor, and in reduced or inappropriately low is insulin. Okay, and glycogenolysis occurs, skeletal muscle breakdown occurs. Okay, so these are the detrimental effects. Whenever there is a stress response, when we talk about one of the things that is pulmonary embolism and everything, otherwise there is tachycardia. So tachycardia is a killer. Okay, whenever there is tachycardia, there is an increased myocardial oxygen demand and reduced supply. Okay, it is predisposing the patient for myocardial ischemia, especially if at risk. Okay, and it will cause hypercoagulability and sodium and water retention because of the hormone. Okay, so now what we are doing, like we are preoperatively we are correcting different things. Like for example, if there is diabetic patient, we have to correct the diabetes. If patient is hypertensive, we have to correct the hypertension. If the patient is anemic, we have to correct the anemia. Okay, if patient is taking any anything which will be causing any morbidity, we will optimize that thing. The components related to surgical component will be that you will be trying to have the minimum invasive surgery. Okay, like concept of this minimum invasive surgery is also related to enhanced recovery after surgery. If you have a laparotomy and if you have a laparoscopic surgery, the results are different. Okay, so they are trying to have minimum invasive surgery. Like if you are doing like open thoracic surgery versus thoracoscopic surgery, the outcome will be different. Outcome will be fast. Okay, so these are the surgical factors. As here written, smoking cessation. The effect of smoking will be gradual. Okay, ideally the smoking cessation should be 4 to 6 weeks. Okay, and in the West, and the people will have this alcohol consumption, which also need to be optimized. Okay, so and as I mentioned before a number of times about the preoperative anesthesia risk stratification and optimization. So you have to chalk out any pulmonary risk, cardiac risk, renal risk, and as much you can reduce. That will be part of it. That will be part of protocol of enhanced recovery after surgery. Okay. Okay, and the other thing will be that you will be having minimum NPO. Okay, the surgeons will avoid to have bowel preparation. Okay, and they will try to reduce the drains, reduce NG, Foley's. Okay, because all of these will be delaying the recovery. Okay, and as we discussed that we will try to use the medications which have less metabolism and less hangover. Okay, so okay, intraoperatively, as I discussed, that avoidance of NG tube, overhydration is a problem, and dehydration is also a problem. So you have to use goal-directed fluid therapy. It is better because if you are doing as I discussed yesterday, that if you are doing a bowel resection and anastomosis and you are giving too much fluid, it will create problem related to the anastomosis. So you have to be judicious in the fluid management. You don't have to be underhydrated, but you don't have to overhydrate. Okay, because dehydration is cause of ileus. If you have electrolyte imbalance, it's a cause of ileus. Okay, and if you are overhydrating it, it is also creating a problem. What about use of steroids? Usually we use dexamethasone as a prevention for post-operative nausea vomiting. So single dose dexamethasone does not create too much problems. But if the patient is on chronic steroids, or if you are having a patient in which we are giving a steroid replacement, as occur in any patient with adrenal suppression, or any patient who is taking steroids in the preceding few months. Okay, so in that group, it will have effect. Okay, so that's what actually, it asks, if you just understand this concept, you use it in every patient and you will have very good result in whatever practice you are doing, whether you are formally doing it as an ERAS or you are not doing it. Try to use these things. Okay, short acting anesthetic agents, avoid long lasting opioids where possible, use of epidurals for colorectal surgery. Actually, because this article is quite old. This is of 2010. In recent studies, they have used, as I was discussing yesterday, they are using IV lidocaine. Okay, yesterday I forgot to share the article. Today I will try to share it. IV lidocaine is sometimes used especially in laparoscopic colorectal surgeries in place of epidurals. Okay, so it is one of them because it is giving a very good blunting of the stress response. Okay, and then you are avoiding using of drains and NGs, avoiding overhydration, attention to the temperature control, especially in the extreme of ages. Okay, so temperature control is very important. If the patient is hypothermic, it will prone the patient to a number of problems. PONV, as we already have discussed. Okay, so anesthetic factors we have already discussed, like fentanyl, remifentanil, concept of TIVA. If maybe future is TIVA rather than inhalational agents. Okay, because one of the factor for the dangerous complication of anesthesia is suxamethonium. So in modern anesthesia, in majority of setups where we have sugammadex, nobody is using suxamethonium. Okay, and inhalational agents, yes, we are using it, but maybe in future decades you will see that inhalational use of inhalational agents will be reduced as much as possible. Okay, and what else? Anyone wants to add something? We have discussed these things which we were discussing before, okay, related to PU and V, use of ondansetron versus metoclopramide, because metoclopramide is associated with some of the side effects, extrapyramidal side effects, and actually if you want to have clear effects from metoclopramide, you have to use it in high dose, which you are not using actually. Okay, so ondansetron is a safe medication as except for, what is the contraindication for ondansetron? In that patient, we should not use ondansetron.
Prolonged QT.
QT interval prolongation. Okay, or the patient is taking any other medication which is also a risk. So you don't combine it with what other medications prolong QT, which you can came across.
Antipsychotics.
Antipsychotics.
Amiodarone.
Amiodarone. This also this one antidepressants. Some of the antidepressants, I think, and lithium. Okay. So
Some antibiotics also, sir, prolonged. I think erythromycin or macrolides.
Macrolides, yes. Okay. So early commencement of oral intake. There was a question which I don't find the answer. What is the reason for keeping patient NPO after regional anesthesia? Is there any reason for keeping the patient NPO after regional anesthesia?
No.
So why we keep the patient NPO?
It's basically a practice, or to be very.
I don't keep my patient NPO after regional.
No, you are absolutely right. But in the academic forum, practically, you can stand upright, upside down. Nobody can ask you. Okay, but practically in academic forums, you have to give some evidence. Okay, keeping the patient after regional, maybe because of some surgical indication. This is one of the factor you will tell.
That is only if the gut.
That is not regarding. That is not concerned with the regional. This is, I think, related to the surgery, not regional.
Surgery. No. Just that I'm telling you. What else? If there is any ileus, evidence of ileus, then you will not resume. It is better not to resume NPO. Okay. Yes, it is a vicious cycle. If you keep the patient NPO, it can predispose the patient more ileus. But if, for example, there is documented something, it's better for you to correct it because if you resume NPO before that, then patient may have some vomiting. Okay, so it's an open-ended question. Actually, it's an open-ended discussion. There is no end to this discussion. Different people will have different ideas about it. Okay, so as I discussed a number of times, multimodal analgesia, use of oral paracetamol, NSAIDs. Okay, short-acting opioids. Actually, in Pakistan, we don't have codeine and hydromorphone or these medications which are available in some parts of the world. We can advise oral opioids even after surgery. We can like the opioids which are available easily in majority part of the world is tramadol. Okay, so tramadol is you can advise. But if the patient is having too much vomiting or too much pain, okay, or the patient is not able to pass the urine, you will not discharge the patient. Okay, and because this topic is also embedded with the concept of day surgery, so some of the things are the common things, like if you are discharging the patient, you should fulfill a certain full discharge criteria. If you have to try to avoid the drains, but if there are drains, you have to like optimize them. There should not be any excessive bleeding. Urinary retention is one of the factor. Okay, and control of pain with minimum analgesics. Okay, so any question or any point which we have missed about enhanced recovery? This is a relatively newer article. We will just have a look. Anything extra? I don't think so. There is anything extra. I will just share this link, and you can have, except for the thing which I mentioned to you, the use of IV lidocaine. I don't think so. Nothing much has changed. Okay, and now they are trying to use this protocol for cesarean sections, for orthopedic surgeries other than joint replacements. Okay, so any question? You see, I will share these articles. You might find something extra. Okay. Just a second. I will share you this link and you will find some of the articles about it. Okay. The basic concept, I hope you understand. Okay. Any comment, anything you want to ask before we finish?
Dr. Zishan,
Yes, Dr. Shaz.
regarding the multimodal analgesia, we can add the ketamine also in that scenario, because
Yes, a
ketamine
small
also
dose.
has shown to be a particular benefit in patients if he's on chronic opioid, and dose of low dose ketamine has an association with significant reduction in pain, opioid
Yes,
consumption, and
yes,
nausea,
yes.
vomiting.
Paracetamol, NSAID, dexmedetomidine, ketamine, lidocaine, nerve blocks,
Is there any role for
compartment blocks.
magnesium regarding
Magnesium, you see, remember one thing, dexmedetomidine itself is not analgesic. Lidocaine itself is not causing any analgesia. It is causing membrane stabilization effect. Okay. So magnesium itself is not analgesic effect. It also has a membrane stabilizing effect, and it is modifying the response to the pain. Am I right? Usman, would you like to add something?
I have read somewhere that it reduces the post-operative pain and opioid consumption. That's why magnesium is
Of
useful.
course, remember one thing, whatever thing you are making, you are, just compare it with making food. If you have put something, you have to reduce something. Okay. If you want to have a good taste, if you put similar things together, the taste will be destroyed. And if you are using, for example, something, I don't want to discuss cooking skills, but if you are adding some tomatoes, you will use less of yogurt. Okay, and vice versa.
Okay, I do understand.
Okay, so it's nice to see
Actually, sir,
Dr.
if
Shaista
you are
after a long time. I thought I had already recited Fatiha for you. It's nice to see you after a long time. Okay, anyways, thanks
My
everybody.
pleasure. Thank you, my
Thanks
pleasure.
everybody. And any question any of you want to ask, you are all are welcome anytime. Okay, we will have another topic tomorrow, inshallah. Assalamu alaikum.
Thank you, sir.